It's not an easy thing to do, and you got it there, so that's amazing. The title of your talk is Reducing Intersectional Stigma in Healthcare, Learning from LGBTQ Patients and Their Providers.
Thank you. Okay. Thank you for that very long and generous introduction. Glad I know what got me here now. Okay, so I want to share with you today some key takeaways from my larger study on LGBTQ healthcare experiences across contexts. I have a lot I want to share with you, so I'm going to jump right into it. But first, I want to give you just a little bit of background. So what we know that sexual and gender minorities are less likely to access preventative and acutely needed care compared to their peers. We know that a variety of different types of stigma and discrimination are associated with this underutilization. But we need to know more about what this actually looks like in care encounters, so how it unfolds. And that's something that sociologists, I think, are particularly well-suited to investigate. And there's also a puzzle driving this inquiry. So among heterosexual cisgender people, you may know there's this somewhat well-known gendered trend, which is that women report fewer unmet medical needs. So they're more likely to go to the doctor, theoretically, when they have a health concern. But this trend actually reverses among sexual minorities. So again, sticking just to cisgender groups right now. So sexual minority women report more unmet medical needs than sexual minority men, and heterosexual men and women. So they report the most unmet medical needs. When we look at transgender populations, including non-binary groups, however, the trend reverses again. So this actually it mimics the general population trend. So let's see if I have a little laser here. I do. So here we have, in response to the question, have you avoided care for fear of discrimination by providers? Trans men are actually reporting this to be true much more often than trans women. And over here we have non-binary folks, so people who don't identify as a man or a woman. This is indicating they were assigned male at birth, where this is indicating assigned female at birth. And again, we see some evidence that non-binary folks assigned female at birth are more likely to avoid accessing care for fear of discrimination. So the problem, the sort of urgent problem here is we actually know the least about these populations' experiences in healthcare. So the underlying question driving this project is what is actually happening within health contexts to compel these groups to avoid care. And to give you just a sense of some of the models and theories that are also driving this inquiry, minority stress model, I don't want to spend too much time here, I think we're probably all fairly familiar with this, but this gives us a sense of how a variety of intra and interpersonal level stressors work to get under the skin to diminish health over time, both mental health and physical health. And then I'm also using this concept of structural stigma, which is really developed by Hatzenbuehler and colleagues in sociomedical sciences here. This looks at how stigma at the societal level, so discriminatory policies or community level prejudice, works to diminish health over time for stigmatized groups. But also Hutto and colleagues have updated this to think about how ideologies about gender and sexuality that stigmatize minorities are also a form of structural stigma that in turn diminishes health over time. And then I'm intervening in a couple other areas, missing links in our general knowledge here. So one is embodiment and nonconformity. Evidence suggests that sexual and gender minorities who are visibly stigmatized, which means if an onlooker, any old onlooker, looked at that person, they would probably think that person is LGBTQ, right? That folks who are visibly stigmatized report more discrimination and harassment and avoidance of care. But we don't know much about how this embodied level of nonconformity is shaping people's experiences. And then I'm also interested in stigma within health organizations. So sociologists have a huge body of work that explores how within medicine, gender and sexuality is regulated. And so this becomes a fraught social site for people who don't conform to norms. I have this picture of the DSM here also to remind us that this is a site where sexual and gender minorities historically have also been pathologized. And in response to this, LGBTQ healthcare organizations have been incorporated out of early health-based social movements in order to provide affirming care for these groups, knowing that these contexts are fraught, that people face harassment and discrimination in them. Historically, many people have been turned away from healthcare based on their stigmatized sexual and gender minority identities. These healthcare contexts, their purpose to affirm these patients. But we don't know much about what's actually happening in real time and space here. There isn't a lot of research that has gone in and seen what is affirming patients. So this is a multi-method qualitative study. I use in-depth interviews and ethnography of an LGBTQ healthcare organization in a city that I will not name in order to help protect the confidentiality of participants. But research spanned 2014 to 2017. I took an intersectional approach that was important to me, and that meant that I oversampled people of color. I also worked to think about how my own positionality as a white person, a highly educated person, a gender nonconforming queer person, what that brought to my interactions and the data. And then I also asked patients to identify themselves to me in their own words rather than fill out a baseline survey. So I got a lot of information about participants that way, and also I wanted to indicate to them that they were the people who were in charge of defining themselves in this process. And then I asked them to walk me through positive, negative, most recent, and memorable care encounters in both typical health contexts, but also LGBTQ health contexts. And I took an abductive analytic approach, which is an innovation of grounded theory that encourages that you enter the field with a broad and deep knowledge of the various literatures that are informing your investigation so that you can best attend to those urgent critical gaps that I cited earlier. I also conducted ethnography over a course of a year, and this included interviews with providers and staff, also observation across different areas of the organization, departmental meetings. To be very clear, I did not go into exam rooms and I did not witness patient-provider interactions in those private spaces, but I did observation in semi-public and public spaces here. So ultimately, this broke down around 3 questions. One is, how does gender nonconformity become salient within healthcare interactions? And I want to give you just a preview of the key takeaway I want to leave you with for each of these questions. So that's the preview here. My major finding, as written in that paper that Teo cited, got me in here, is embodied disruption. And this illuminates the process through which providers who are not able to recognize patients' nonconforming identities and embodiments, when that happens, it disrupts the healthcare interaction, and then typically stigmatizing responses ensue. And this leads to diminished motivation to seek care. And I'll illustrate that in just another moment here. The second question is, how is stigma reduced in the context of an LGBTQ healthcare center? And the key takeaway I want to leave you with here is that in this context, employees, providers, as well as patients are co-constructing expansive schemas of gender and sexuality that allow for non-conforming and minority patients to be recognized and affirmed in context. Also, the organizational culture is key here, so I want to make sure I am clear that this is still a very important component of sexual and gender minority healthcare, is having organizations that explicitly cater to these groups. And then one unexpected but important finding is that cis women in these contexts, sexual minority cis women, grappled with this idea that this center was not actually for them. And I'll talk about that more in a moment. And then one emergent finding from this research was the ways that patients and providers perceive weight bias to be shaping their interactions and also motivations to continue seeking care. So among cis women and also transmasculine people, weight bias, when they perceived weight bias, they felt discouraged about accessing future care, often fell out of care. And I think this data makes a good argument for a harm reduction approach to addressing weight and weight-related health concerns, and I'll speak more about that in a moment. Okay, so now I want to illustrate these takeaways for you. First of all, to answer this first question, to be clear, in this case, I analyzed 34 of the 50 overall patient narratives, and I included trans men, non-binary people, and cis women with non-conforming gender presentations, so masculine gender presentations. And I am conceptualizing non-conforming here not in the sense of an identity, but as a group of folks who do not conform to narrow, typical medical definitions of sex and gender, wherein sex, identity, and embodiment are assumed to align in discrete and binary ways. And this is, you can read more about this in this paper. So again, the central finding here is that when providers couldn't recognize non-conforming patients, or they made incorrect assumptions about patients based on the information they did have, this led to a break in the healthcare interaction. So when we go to the doctor, we expect care to unfold in a certain way, and this became a rupture in that interaction. Patients described distress in response to this. When it happened, they had a very emotional process, or they described an emotional process where they were balancing wanting to get their healthcare needs met with avoiding what they thought might be the fallout from this moment of rupture. And they tended to prioritize avoiding future disruption over getting their healthcare needs met. So responses to this rupture are really key. And this is important for folks who want to intervene to create more affirming care for non-conforming patients in particular. I categorized provider responses interpreted to be stigmatizing in 4 ways: disengagement, sorting out, denial, and disciplining. But I want to focus on disengagement today because I think we can all sort of understand more overt forms of harassment are stigmatizing. We know what that means. We can intuitively understand that. But disengagement was actually the most common response. It was often followed by others, but most common. And that alone was enough to drive many people away from returning for care. So Clay's story. Clay uses they, them pronouns, is non-binary. They went to get an EKG. They said they went in, and they said that sort of the nurses came at them quickly, brought them to a semi-private area, and then, in their own words, I was just awkwardly kind of leaning back on this chair. I had all my clothes on, and she asked me to lift up my shirt, she being the nurse. And when she saw my sports bra, she seemed really confused. She stopped talking, and it was clear that she was uncomfortable with what was happening. So again, this can be a very subtle moment, right? Clay draws from this, interprets this to mean that the nurse thought Clay was a cis man, and so was asking Clay to lift up their shirt because that would not be an invasion of privacy in the same way it would be for someone who's not a cis man. And the result is this moment of rupture. The nurse stops talking. Misrecognition has clearly happened. She's confused. And Clay, after this interaction, does not go back to seek, doesn't return for results, doesn't follow up with care, and doesn't get this health need met. When I looked at differences by race and ethnicity, I saw that people had similar experiences. However, patients of color had reported first added race-based bias, and then they also had this another dimension, I'll call it, of stress here, because they had to sort through where bias was coming from. So this is Corey saying, I don't know what problem you're having with me, but you're having a problem. And of course, luckily, there are exceptions to this rule. And the exception is recognition and affirmation. And this often happened in LGBTQ health settings. Which brings us back to this question, which is, how is stigma reduced in this context? To answer this, I'm analyzing in the paper responding to this question, I'm analyzing all of my data, but today I'm going to focus on the patient narratives and provider narratives. The general takeaways, this is a paper called Queering the Clinic, Constructing Gender and Sexuality in LGBTQ Healthcare. So first of all, I was surprised that providers really pushed back when I asked them what was important about caring for these populations by saying it was just like treating anybody. There's nothing different about it. Things like we all have hormones in our bodies. And that instead, what they were telling me is that gender and sexuality both are fluid, diverse, and subject to change over time. So they were instead creating expansive schemas of gender and sexuality that could normalize and destigmatize minorities. What they were doing explicitly, however, also informally, this wasn't codified in, or organizational policy, right, is they were what I call queering center space. So they're actively constructing the culture of the organization to reflect the sexual and gender cultures of their patient populations. And altogether, there was this, what I call advocacy ethos that organized the center as well, where there was this idea that patients, providers, staff were all responsible for the common goal of uplifting LGBTQ health. But cis women in this context also struggled to think about whether or not that meant they should be in that space, whether or not they were deserving of that space, which left them feeling that if not there, then where? So an example of the deployment of these sort of destigmatized, expansive schemas of gender and sexuality is the provider telling me that in terms of gender, it's really unknowable. You can't capture it because it might change over time. And they say, same thing with sexual orientation. We were trying to collect that information, and it was such an obscure question. Trans women would say, I guess I'm straight. Hadn't really thought about it. Well, now I guess I'm gay. But when I get my breasts, I think I'll be straight, or whatever. So I sort of stopped asking. I don't think it matters so much as who you're having sex with. I think we're pretty good at that, sticking to the details that matter. So instead, drawing focus to what you need to know about a patient in terms of behavior, desire, actions that allow you to care for that patient. And Gabriel offers an example of what it felt like to receive this expansive schema. So Gabriel also uses they, them pronouns. I'll just preface by saying they were looking for a letter that would allow them to get top surgery to construct a male contour chest. But this was stressful for them because they don't align with binary notions of transgender. So they say, I was definitely extremely nervous, pretty pessimistic. I don't know any doctors or clinics anywhere that really serve trans people in the way the center does. So what am I going to do if she says no? I identify as androgynous. I don't really feel like a man all the time. But I know that top surgery is for me. I know that I really want to do this. I definitely need that letter, and I'm going to find a way. But they were pleasantly surprised by the provider's response. She's just like, chill out. It surprised me. We had an entire conversation about gender and how medical professionals shouldn't be dictating what you do and don't need done. She was totally there with me in terms of, I understand if you feel this way. That's how you feel. I'm going to be your supporter 100%. And I appreciated that. All that stress and nervousness just went away. So while Gabriel is really benefiting from this expansive schema, Kathleen is a cis woman, bisexual cis woman, who reads these signals to actually mean that she might not belong there. So she says, she's talking about filling out an intake form and says, I remember checking no, 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 no. I said, about gender dysphoria and gender identity? She says, yeah. And I was like, do I fail? I answered no to everything. I answered yes to one thing. Have you experienced depression? Have you been on medication? But I checked no to everything else. Is there a place? Do they care about helping someone like me? Likewise, Amelia struggled to think of multiple reasons why she would be deserving of care here rather than just her queer identity. So she says, there's never been a focus group flyer that had anything to do with any of my identities. But between being low income and being queer, it made sense to go there. I hear now it's impossible to get in unless you identify as someone who is HIV positive or trans. And I feel a lot of conflict about whether it makes sense for me to still go. I feel like I'm taking up space. If I'm going, does my low-income trans woman friend who's 22 get services still? So you see here cis women taking it upon themselves to think through whether or not they're deserving of that space, reading signals from that space to mean that this is not actually a place for them, but for more deserving patients. So this is important, right? Because as we talked about in the beginning, sexual minority women are not getting their healthcare needs met at the same rate as others. So another emergent finding was that perceptions of weight bias were a key barrier to care for cis women and as well as transmasculine patients. So in this paper that's currently under review, I am analyzing all data again, but in this presentation I'm going to just focus on patient narratives. So just a note on terminology. Fat was actually the preferred term among patients, whereas the use of obesity and overweight were interpreted to indicate bias or to be stigmatizing. Patients also use words like fat phobia and fat shaming. Providers often use words like sizeism to describe weight bias. I know there's no one word that will represent everybody's preference, but this is what emerged from this sample. And then this is sort of the key, what makes it different for this group in particular is that participants here interpreted weight-related stigma to be intersectional. So it was inseparable from stigma perceived about gender, sexuality, and race. Some examples are fat femmes as a sexual identity, an embodied sexual identity, the idea that queer people and trans people and lesbians and bisexual people have embraced body diversity, and also that being different does not mean ill. So as an example of the interconnectedness here, Ray says, I haven't gone back because they're just going to tell me to go on a diet. If people are that clueless, that bodies come in different shapes and sizes. I feel like that's part of being queer. People have different bodies, and pathologizing my body, pathologizing a part of my body, that's not illness. Here I just want to highlight that when patients did perceive weight bias, they also primarily felt themselves to be at risk of misdiagnosis. So there's community health knowledge that informed this interpretation. Amelia says, as a fat person being in a doctor's office, seeing at what point that gets brought up, to what extent and how far it gets pushed makes you wonder, gauge the quality of care you might anticipate. So if it's an immediate thing or someone's pushing it a lot, you think, okay, well, this person's not going to see the larger picture, right? This idea that they'll be distracted by this issue. She says, and luckily I haven't had any really misdiagnosed serious thing, but there's stories of people, fat patients of course, who had cancer and they were told to lose weight, but turns out something was terribly wrong. And then I want to highlight this idea of fat broken arm syndrome. Has anyone heard of trans broken arm syndrome? Yes, one. Okay, so I'll read this part and then I'll explain more. So Corey says, I never got diagnosed with diabetes because providers always just chalked it up to me being fat. They're like, well, have you tried not being fat? There are probably articles out there about trans broken arm syndrome, as they call it. Fat people have the same experience, if not amplified, depending on their level of fatness, etc. So trans broken arm syndrome is an idea in the trans community that if you go to the doctor's office with a broken arm, the doctor will say to you, it's because of your trans care. It's because of your gender affirming care. So attributing a health concern to someone being trans because somebody doesn't understand what that means. And it's the most visible and salient issue that a provider interprets from that interaction. So, you know, it's a joke, but it has its roots in real experiences. So the idea here is that if a fat person goes to the doctor's office for a broken arm, that someone will say, have you tried not being fat? That's the illustration that this patient, the connection the patient's making here. So he continues and says, I've actually posted on Facebook. I'll post those articles together. I have a lot of fat friends. I have a lot of trans friends. And I think sometimes people don't look at the overlap. So again, how this particular group of people is multiply marginalized, and when they're going into these spaces, anticipating bias that's intersectional based on a variety of embodied identities. Luckily, there are also positive experiences, and discussions with patients and providers highlighted some of the key ways that patients preferred and that providers had experienced success in talking about weight. And these actually apply the same patient-centered harm reduction approaches that are already in play in this context, the LGBTQ context, in order to destigmatize other stigmatized health behaviors like risky sexual behavior, substance use. So those approaches are already developed, right? These include things like building familiarity with a patient and their mental and physical health concerns before broaching a subject like weight, determining patient health goals and behaviors. What are that patient's diet and exercise now? Do they want to lose weight? Have they tried losing weight? Do they have an eating disorder? Is there anything else that you need to know before having that conversation? And then health at every size is an example of a movement that already exists, a framework that already exists for supporting patients where they're at, regardless of their goals about weight. So to sum up, this study seeks to answer these three questions. How does gender nonconformity become salient in interactions? How is stigma reduced in an alternative context, the LGBTQ Healthcare Center? And then how are patient and provider perceptions about weight shaping interactions? And again, the key takeaways I want to leave you with today is this first, embodied disruption contributes insight into the process through which misrecognition of minority embodied identities disrupts care interactions, and in turn leads to stigmatization, which diminishes motivation to continue seeking care. Whereas in the LGBTQ Health Center, we see how expansive schemas allow some of these same patients to be recognized and affirmed. At the same time, cis women feel that this is not a place for them. And this is important because cis women are not accessing care at the rates that we want to see them accessing care at. And then finally, among cis women and also transmasculine people, weight bias emerged again as a key barrier. This is particularly significant because sexual minority women, we know, have higher BMIs on average than heterosexual women. So patient experiences and also provider narratives in this context illustrate how a harm reduction approach can be used to encourage adherence and utilization among this group. And then in general, theoretically, these studies contribute by emphasizing the importance of examining embodiment and nonconformity in our larger understanding of how minority stress diminishes health over time, as well as how you can intervene at an organizational level to affirm patients and work to ameliorate stigma. And that is my talk. Thank you.
Thank you, Emily. We have time for a few questions. I see 1, 2 questions. Okay, 2 questions, that's it.
And this is excellent, really interesting and well visited. So I know you were more observing what was occurring. I'm wondering about the implications for how to repair an embodied disruption and whether you heard something from them about that.
Yeah, that's a great question. Thank you. I should say I'm also writing a book based on, this is my dissertation study. And so I'm getting to go into more detail about things like that I really want to get at. So yes, positive interactions, affirming interactions. Affirming is sort of the best case scenario, but a good enough scenario is if there's a misrecognition and a patient has to correct you, you say thank you, and then you just move on, right? The rupture itself triggers stress for patients because they've had such negative experiences of what comes next. But if you can just say, thank you, and then move on, that signals to them that your own discomfort about what just happened isn't going to diminish the care that they're about to receive, if that makes sense.
Yes.
Mm-hmm. Yes.
This is awesome. You brought up something that I think about a lot, which is that, when you talk about the cisgender patients not feeling like, that space is for them, and it's a space that's really been transformed in many ways to handle a lot of the issues that you bring up. Mm-hmm. I wonder if you think that it is possible to create a space where people who have kind of walked through life, within a society where they have tons of kind of structural and societal power, and those systems are built for those people. When those systems then change, and then see all these different signifiers that are trying to affirm other groups, and the reaction is, oh, this might not be for me, I don't feel comfortable here. Do you think there are aspects of things that you observed where there could be a model that harmonizes both of those? Because I feel like, is it just that we have to have LGBT health centers that are kind of focused on a patient population versus a large, clinical center that is for everyone when really it's catered to a certain group versus one that brings aspects of them together?
Yeah, that's the $1 million question. Thank you for asking. A couple things. One, I didn't get into this much, but even though these expansive gender schemas really benefit gender minority patients in particular, the sort of general tone of the organization actually caters more to cis gay men, and cis white gay men are the most visible force and in positions of power. So I would push back on the idea that cis women are walking into the space as people who experience more privilege than cis gay men, for example, if that's the population that is centered here, and it is. I think that LGBTQ centers can't do it all. I think that sexual and gender minorities are extremely diverse and have extremely diverse experiences and embodiments and interests, and it is too much to ask one place to do everything. At the same time, I think more needs to be done because that's what we have, right? And part of what I'm developing in terms of the misrecognition piece in the book is that cis women are misrecognized for being straight women in typical health contexts all the time. And that is actually a significant barrier that causes stress. It makes people not want to go to the doctor. It might seem, again, like disengagement. It might seem subtle or sensitive or whatever to us, but it's enough for them that they don't want to do it. So if that alternative space that advertises itself as being for them, they go in there and some people were still misrecognized as being straight women, for example, if that's perpetuated there as well, it is really important that there's no place for them. Does that answer your question?
I think it starts to.
It's.
I mean, it's not. There's no real.
Yeah.
Ask your very good question.
Thank you.
Emily, thank you so much.
Okay.
Okay, and now it's my pleasure to introduce Bisrat Abraham.
Yes, Abraham. Either one, yes.
Bisrat is a medical doctor, infectious disease physician. She works as the Director of Clinical Operations and Technical Assistance within the Bureau of HIV/AIDS Prevention and Control at the New York City Department of Health. She was trained at Emory, and she did her internal medicine residency at the Johns Hopkins Hospital. Mm-hmm. And then she moved, she became a disease detective. I've never heard that term. A disease detective. Sherlock Holmes.
I did, yeah.
Trying to find the disease. She joined the CDC Epidemic Intelligence Service within the Division of Tuberculosis Elimination. Then she moved to New York City. She got a fellowship, an infectious disease fellowship at the Weill Cornell Medical College. And she stayed on as faculty, still connected to the college. Mm-hmm. But in 2015, she joined the Department of Health. And in her current role, she oversees training, technical assistance, and capacity building activities for clinical and social service providers across New York City. She also oversees a CDC-funded capacity building assistance project for health departments and community-based organizations nationally. That's quite a responsibility, especially after this conversation.
Yes.
And in 2018, she was awarded a pilot study from the HIV Center, and she's going to share a lot of interesting findings from that study with us. Thank you and welcome.
Thank you. Thank you. Thank you so much. And I'm going to keep sitting, but thank you so much for that lovely introduction. I've had a lot of training, basically, like my whole life. So today I'm very excited to speak to you about work we're doing around rapid treatment of HIV, which we at the New York City Department of Health also call immediate antiretroviral therapy, or IART. And we'll get into definitions in a few slides, but basically it's the idea of starting treatment for HIV as soon as possible, ideally on the same day that it's diagnosed. And it's actually not the standard of care within the United States, not yet. But you know, there have been recent examples of success with rapid treatment models from San Francisco, Baltimore, Atlanta, which show that it is feasible to enroll clients or start them on treatment on the same day of diagnosis, and that it has, positive outcomes for patients. So this is something that's sort of become, as part of our ending of the epidemic effort, the latest activity to promote this. So this pilot award actually was really useful. It allowed us to assess what's happening in New York City among clinics and what provider awareness, knowledge, and practices are related to rapid treatment. And the results I'll share with you today are actually already informing our scale-up efforts. So I have a lot to cover as well, so I'm going to try to talk fast. We're going to go through background, methods, results, and discussion. So many of you probably, many of you probably have seen this epidemic curve. If you've seen any of our talks, this is usually the first slide that we show. It shows how far we've come with our HIV epidemic from the early days in the early 80s all the way to the most recent 2017 actually is the most recent surveillance data. We will be releasing 2018 data very soon, in a matter of a few weeks. But basically, you can see new AIDS diagnoses here in the red and HIV-related deaths in the green line, peaked in the early to mid-1990s and came crashing down with the introduction of highly active antiretroviral therapy. So as a result, we see the total number of people living with HIV, the bars here on the right, has continued to rise annually as people are successfully living with the virus. And this line here, whoops, sorry. I don't know if you can see it, it's a black line. It represents all new HIV diagnoses. Prior to that time, all that was reportable were AIDS diagnoses. In 2001, laws changed, CDC requirements changed, and we started capturing both AIDS and non-AIDS cases. So that's new diagnoses, and we really closely track that number. And in 2017, we had a record low at 2,157. Although that's like the lowest it's been, and the 2018 data, I believe, show another reduction. If you look at the case rate, it's still 25 per 100,000. So that's much higher than the national average of about 14 per 100,000. So we're still diagnosing a lot of HIV here in New York City. So it's really important to, not to get complacent and to continue our efforts. So I mentioned we're in the midst of an ending of the epidemic initiative, which is a citywide, statewide project, essentially. This blueprint, this blueprint was released at the end of 2014 and really implemented in 2015. And the goal behind our ending of the epidemic project or initiative is really to reduce prevalence. So as I showed you on the prior figure, prevalence, the total number of people living with HIV has continued to rise annually. With ETE, the goal is to really start to bend the curve to reduce prevalence by bringing incidence down. And the blueprint details three big goals, or pillars, we call them, of ETE. The first is to diagnose all people living with HIV who are out there and remain undiagnosed. So it's all about testing. The second pillar is to really focus on treatment, to link, retain, and virally suppress all people living with HIV. So they remain healthy, and there's also less onward transmission. And that's really invoking the U equals U message, undetectable equals untransmittable. And then finally, prevent new infections by promoting access to pre-exposure prophylaxis. It's really PrEP, PEP, syringe service programs, any prevention strategy, but PrEP was specifically called out because back at that time, 2014, 2015, it really wasn't implemented. The guidelines had just come out, not many people were on PrEP, so that was really called out specifically. And by the way, I think many of you know there is now a national ending of the epidemic initiative as well, very similar to this. And money are already being allocated for this national effort, so there's even more urgency. As far as rapid treatment goes, it really is focused on the second pillar, which is all about treatment and maximal viral suppression. So this is the care continuum for New York City, again, using 2017 data. And we're not doing bad. We're doing pretty well relative to the rest of the nation. You can see here, this would be all the people living with HIV. We estimate 93% are diagnosed. That's really good. So there's 7% of people who remain undiagnosed. Nationally, it's about like 14 to 15%. So we do a good job of testing. We can always increase that number. And the goal here, of course, is to get every bar as close as possible to 100%. We link about 89% of people, 86% are retained, 80% are prescribed ART, and 74% are virally suppressed. So you can see there are gaps in linkage still, and there are gaps in ART initiation. And we think rapid treatment models can help to address those gaps. They have in other settings. So this is sort of the definition. What do we mean by rapid treatment, or we call it immediate ART initiation? And funny enough, the terminology varies across lots of settings. So we within the Bureau of HIV, we call it, or have coined it, immediate ART or IART. Our state colleagues actually at the New York State Department of Health call it rapid initiation of ART or RIA. Within our own health department, the Bureau of STI, they call it Jumpstart, and San Francisco calls it Rapid. So basically, it's all referring to the same thing. It's really, what we're considering rapid or immediate is if ART is initiated as soon as possible after diagnosis, ideally on the same day. And it's oftentimes initiated before results of confirmatory HIV testing, before results of resistance testing, and even baseline labs. So typically someone's diagnosed, you can draw those labs, but it might take a few days to get the results. And so the question here is, what do you do? We're recommending starting treatment. And even with a preliminary positive, a rapid, whatever test you get, you start treatment. That's what we're suggesting or recommending. We do know that, and this is sort of just we had to come up with a general timeline for what we're considering as rapid. And there are times people are diagnosed on, say, a Friday and can't get access to the treatment because of insurance barriers until a Monday. So we're saying anything from 0 to 4 days. Ideally, again, it's on the same day. But if it's started within 0 to 4 days of diagnosis, even with a preliminary positive, we do call it immediate. It is relatively immediate. So this figure kind of shows you the old paradigm of how we treated HIV, where it takes days, weeks to months to go from diagnosing someone to linking them to care, to eventually having another appointment to prescribe ART. Hopefully they're retained, and then you eventually go on to achieve viral load suppression. So it's a very linear process that takes time, and historically has not been a lot of urgency around it. We are, with the rapid treatment models, sort of rethinking that time and process such that diagnosis, linkage to care, and ART prescriptions all happen ideally on the same day of diagnosis. And with that, we hope that you therefore shorten the time to viral load suppression. So this pilot that we were fortunate to get, it had 3 aims. The first was to identify a group of clinics with varying levels of readiness to implement IART, and I'm going to call it IART from now on. And so we wanted to get a sample of clinics to basically sample for the survey. And we did that by triangulating a lot of different data sources on viral load suppression. We know there are some clinics that perform well and have like 98% of their clients virally suppressed. Some can only achieve, 50%, 60% viral suppression. And also we know there are varying levels of organizational capacity. So we tried to capture a representative sample. Then the second aim really was the bulk of our study. We sought to assess HIV clinic staff knowledge, attitudes, and current practices around IART, as well as experiences and general clinic readiness to implement it. And we did that through structured surveys, basically CAP surveys, and in-depth interviews. And then finally, our third aim was to engage clinic staff and other key stakeholders to share those data and to come up with a strategic plan for implementation of IART citywide. So the pilot was a very nice collaboration between my program within the Bureau of HIV, Clinical Operations and Technical Assistance, as well as CUNY's Institute for Implementation Science and the HIV Center. All right, so as I already mentioned, in terms of the pilot study design, it used a mixed methods approach with a quantitative structured survey, and the qualitative component entailed in-depth interviews or IDIs. We used purposive sampling to get a group of clinics, and we ensured a diverse representation based on health outcomes, such as VLS and the total number of people newly diagnosed that are identified within the clinics. Also varying levels of clinic resources, such as having formalized, right before this pilot actually, we awarded several contracts, testing contracts that incentivized IART. So we took that into consideration. And then of course having an on-site pharmacy can facilitate IART, so we looked at that in getting our sample of clinics, and then clinic location by borough and type, whether they're hospital-based or community-based. So once we identified our group of clinics to sample, we identified at least one clinical and one non-clinical staff member from each site. And we sent them recruitment emails to complete the quantitative portion of the survey, or quantitative portion of the study, which was the survey, structured survey. And for those who responded, they were given the option to opt in into the IDI component. And those who completed the IDI actually were asked, and this was really to increase our sample size, we did some snowball sampling. So they were asked if there were other people that they could recommend for the study. All right, so I have a lot of results, and I'm going to try to fly through it. So first, we're going to look at the survey responses. So at the clinic level, we sent the survey to 30 clinics. You can see here, a total of 30 clinics across all 5 boroughs, with the largest number of clinics being in Manhattan and Brooklyn. And individuals in 25 of these clinics, so 83%, so that was a really good response rate, responded. So individuals in 25 of those 30 clinics responded to the structured portion. And then for the in-depth interviews, we had participants in 13 clinics, which is 43% of the clinics respond to the survey. Oh, you can see here on the map. At the individual level, you can see that we had a total of 46 respondents to the quantitative portion of the study, and 17 of them went on to complete the IDI. And you can see that we had a good spread between clinics that were high, relatively well performing in terms of VLS, as if you look at that particular outcome, as well as people who held clinical and non-clinical positions. So we had a pretty good spread. And then this figure shows the different roles held by the participants. There were 16 who held clinical positions, and that included physicians, nurse practitioners. 13 were administrators. So this group represents our non-clinical. So 13 were administrators. That included practice managers, administrative coordinators, and then we had 10 social service providers, so social workers, patient navigators, who are critical, by the way, to the IART, implementing IART within a clinic. And then we had 6 people that held dual roles. So they were a clinical provider, but an administrator as well, or a social service provider who also did some administration. All right, so the first group of responses are related to respondent knowledge. So more than 80% of respondents correctly identified that IART decreases time to viral suppression and increases patient retention. And these are findings that we know from San Francisco and other international studies that have been done around rapid treatment. Also, close to 70% of respondents correctly stated that having a consistently undetectable viral load for 6 months eliminates the risk of sexual transmission of HIV, or U equals U. And that's important because that's a big motivation, particularly for patients, for rapid treatment. Okay, so next is all related to respondent attitudes about IART. So we asked the respondents about the timing of IART or ART initiation and various baseline tests. And we gave the scenario that the initial positive test is a rapid positive test. So 80% of respondents agreed that ART should be initiated on the same day of a reactive test. 67% agreed that ART should be initiated within 3 to 4 days. And then in digging deeper in terms of timing, 50% of respondents agreed that ART should only be initiated after a confirmatory HIV test. But the large majority of respondents disagreed that ART should be initiated after baseline testing, which includes kidney, liver function tests, genotype testing, and other HIV labs like CD4 viral load. So in other words, this 50% of people were really uncomfortable starting rapid treatment before a confirmatory test. They really felt like they had to confirm the diagnosis. They didn't want to start folks on a preliminary positive for fear that it's a false positive. But other labs, it's not as necessary to have to wait for those results to come back. So next, the data from prior, we actually stratified by respondent position, and you can actually see a difference in response. So it looks like non-clinical respondents were more likely to want confirmatory testing and were more likely to want baseline HIV lab testing. So there's a little bit of a difference, although even the clinical folks, it's still 30%, 35%, are still a little nervous about starting before confirmatory testing, but it was most, visible for the non-clinical respondents. At least 80% of respondents agreed that IART was important for viral suppression, patient retention, and overall patient health. However, between 7 to 11% of respondents reported that IART was not important, or that they were unsure if it was important for these three outcomes. So there's room in terms of training. So next, we asked folks what populations they felt would benefit most from IART, and if there was any hesitancy around specific subpopulations. So newly diagnosed and previously diagnosed individuals who are treatment naive, so they've never been on ART, were deemed as most appropriate for IART, followed by recent PEP users, recent PrEP users as well, who, unfortunately may have converted. Now, only half of respondents identified previously diagnosed individuals as being who had received ART. So previously diagnosed but received ART as being appropriate for IART. And in reality, they are appropriate for IART. You can start them if they re-engage on the same day of diagnosis. It's a little more complicated because you have to look at prior regimens of ART just to ensure they didn't have resistance. But it's very doable, and we recommend doing it. And then interestingly, only about 40 to 50% of respondents identified individuals who use substances, are unstably housed, or have mental health issues as being appropriate populations for IART. And this is problematic because we know from the San Francisco experience and from Baltimore that these populations absolutely benefit from IART, and it actually might be even more important for capturing them early. And so this is an area that we took mental note. We need to do more work to educate folks. And there's also a historical notion around HIV treatment that we sort of need to break down, this idea that patients have to be ready, that they have to be in a very stable environment. We have to deal with all of their other social issues before we start treatment. Because if they get on treatment and they're not adherent, resistance can develop. So, and with the new treatments, we know there's a high barrier to resistance. We know they're life-saving medications. And so this is sort of a big area of work for us with the providers. Okay, so how are they doing in terms of, what are they doing within their clinics? What are their current practices around IART? So we found only about 22% of respondents are initiating ART on the same day of reactive test for all or more than half of newly diagnosed patients. And in fact, 24% said they did not do this for any of their clients. 39% reported initiating ART within 3 to 4 days of reactive test for all or more than half of their newly diagnosed. And with regards to lab testing, the majority of providers started ART before results of HIV genotyping or baseline HIV lab tests like CD4 and viral load. But fewer providers were doing this, were starting ART before results of confirmatory HIV tests and before baseline lab tests. So the baseline lab tests, just checking kidney and liver function, some felt like they needed to get those results before starting treatment. And this here is an interesting finding. We asked providers about the time it takes from diagnosis to ART initiation. Among all respondents, you can see 66% reported 0 to 4 days as the typical length of time from a positive HIV test to ART initiation, though only 18% reported they're doing it on the same day. But then when we stratify by race, we see that clinics serving a majority of people of color were less likely to meet the same-day benchmark compared to clinics serving majority white clients. There was a discrepancy here. And this needs to be further explored. It's possible that this could be a result of underlying differences in clinic resources, for example, having enough staff and for example, navigators and case managers to do all the paperwork that's required to get ADAP and other insurance coverage, versus, and also having on-site pharmacies, versus provider bias in who they're prescribing ART to, based on what I showed you before on populations that they think may not be suitable for IART. So this is an area for further exploration. We asked toward the end of the survey about facility level challenges to implementing IART, and the most commonly cited barriers were medication, trouble with medication prior authorization, financial barriers, also this risk of false positives. And I should just footnote here, so the latest HIV tests, the 4th generation combined antigen antibody tests, there have been reports of some higher rate of false positives. And that's actually been the experience of our providers within the sexual health clinics. And it is higher than prior tests. Nonetheless, we're still offering rapid treatment. And I think there's language that, when you introduce the idea of ART to the patient, letting them know we're starting this and we're going to confirm in a few days. So there's ways to get around that, but that was cited as a challenge or, one of the issues. And then similar to the last question, we asked about patient-level challenges to implementing IART, and the most commonly cited were insurance barriers, psychosocial barriers, and financial barriers as well. Okay, so I have probably 5 minutes to cover this. So this slide is very busy, but summarizes our findings from the qualitative component. It shows the various barriers and facilitators that were conveyed to us by staff as they go from the stage of diagnosis to ART prescribing or prescription to getting access to the medication for their clients. And overall, the interview findings corroborated results from the structured survey. Interestingly, while most providers cited the importance of IART, some also questioned its importance in terms of starting same day versus within a few days of diagnosis. And I'll read to you some quotes from the participants. So one participant said, "In the back of my head, honestly, are they, meaning those who started same day, really doing that much better than the people that it took us like 3 days to get started on ART? Is the difference in the outcome enough to justify all the extra effort and extra use of staff and extra hours?" And then here, this is at the diagnosis stage, we found that rapid treatment initiation relies in part on where the patient is diagnosed. Some sites are better than others at conducting rapid testing and responding quickly to positive results. So for example, patients may be tested in the emergency room, but they may leave before results are even back, and getting them started on the same day is a challenge. So one person said, "When the test results might come back, the patient's no longer here in most cases, so there will always be a lag between when we get notified of the test result that wasn't done by us and when we reach the patient and get them to a clinic that can prescribe ART." PrEP, according to some respondents, may have also helped make patients and clinicians more accustomed to the idea of rapid treatment. So one participant said, "A lot of people coming in for PEP or PrEP are obviously thinking about the risk of acquiring HIV. In that way, my sense is that they're more likely to engage in it." And then finally, respondents varied in their views about initiating treatment based on rapid testing. Some were concerned about potential emotional distress in the event of a false positive, and were reassured by evidence that current regimens have a high barrier to resistance and a good safety profile. So one participant said if the pharmacy has to give 30 days of ARV, it could result in logistical problems, insurance problems, emotional distress for not a lot of benefit. Another said the benefit will far outweigh the risk of allowing ongoing viremia and the consequences from immune activation and transmission risk. So at the prescription or prescribing stage, a commonly cited facilitator was having dedicated and collaborative teams that can help schedule the visit and make sure things are going smoothly. So I'm not going to read all the quotes. Respondents also reported that there's a tension between meeting patients where they're at, meaning being responsive to their concerns, and advocating for rapid treatment as the standard of care. So one participant said, it's going to be patient-centered. Another said, I kind of move away from the psychosocial elements and patient readiness, and I'm just like, hey, the drugs are going to work. And then at the stage of obtaining meds, respondents reported some strategies they had for obtaining coverage through ADAP, but still reported challenges. Social workers know they don't have to have every single item of documentation to get data set up. And then another said there's no space for rapid test results. That's the ADAP challenge. So ADAP was repeatedly cited as a barrier. And then starter packs and coupons helped, so did having a pharmacy on site. And if they didn't have it on site, having relationships with the pharmacies. So in general, just obtaining the medication is really really the biggest logistical challenge. Because if the person is uninsured, how do you get insurance set up and, the prescription cleared all on the same day? And I'll share with you at the very end updates. There have been huge updates around the ADAP process, enrollment process that now allows people to get enrolled very quickly, low threshold. Documentation could be submitted, up to 21 days later. So that's been great. All right, so just quick summary. So a lot of data, sorry. So knowledge, attitudes, high levels of knowledge around the benefits of IR, some differences between people who held clinical versus non-clinical positions. And overall, it was cited as being important in achieving outcomes and important for most populations. And general agreement that it should be offered soon after a reactive test with that concern around providing treatment prior to confirmatory testing. And then interestingly, that hesitancy that we saw around the provision of IART for folks who may struggle with substance use disorders, have immigration issues, mental health disorders, or housing instability. In terms of practices, we confirmed access to IART is not yet the standard of care across New York City clinics. Only about 20% are doing it same day. And disparities may exist across racial demographics. And supports are needed to help with financial and insurance barriers. And implementation definitely requires a multidisciplinary approach. Here are some limitations to our study. It was a purposive sample, but we sought to get a variety of respondents, but it may not be generalizable to all New York City clinics. Also, we did not get the patient perspective, you'll note. And so that's something that's important. We actually held a stakeholder meeting. I'll show you a picture of it in a slide. And that was something that, folks wanted to see more of. So I think there's work ongoing to kind of address that, and, we're figuring out ways to get that feedback. And then potential response bias. There were some clinics that we contract, and IART is one of those reimbursable activities, so they may have wanted to please us in their responses. So this was the third aim, to hold a stakeholder meeting. We held a stakeholder meeting a few months back, actually. It was very successful. We had over 90 participants from 35 different agencies, packed room. We had provider and consumer panels. We invited folks from the state to come, specifically the ADAP gurus. And they actually have done a major overhaul of their enrollment process, so it can happen same day. They now have a staff person that covers the phone lines, I believe 24/7. So they talked about the latest updates and how to fill out the forms. and lots of discussion. We talked about the risk of false positives and there are adaptations that some clinics who are successfully doing IART that they've made, like doing double testing with HIV rapid tests of different technologies. So if one flags as positive, they, kind of confirm it, increasing their confidence in the test. There were concerns about from, I believe, a navigator about, well, we know patients are selling their drugs, and if someone's viral load just doesn't come down, do you withhold treatment? And lots of discussion was had, so very informative. And basically, this is my last slide. There are a lot of efforts that we're undertaking to expand IART. It's sort of the latest, like I said, latest activity within our ending of the epidemic work. So very similar, we are actually doing a lot of work similar to what we did for PrEP to expand PrEP access. So the first activity is promoting IART to patients. We're doing that through our social marketing campaigns, which are very sex positive, LGBTQ friendly, and we are really trying to promote the U equals U messaging to patients. We also have a provider directory that lists IART as a service that they can search for, and they can identify providers that are offering it nearby. And then another group of stakeholders that are really important, the providers, because we know they're not doing it and they have concerns. So we're promoting it to them through a lot of guidance documents. So the state actually just released, like a month or two ago, just released guidelines around rapid treatment, really promoting it, walking providers through it. Also, a Dear Colleague letter co-signed by the city and the state was just released last week. So it just came out, really urging providers to start treatment same day. And then we're doing a lot of training and technical assistance. We have a rapid treatment training at Gotham at the health department that we're offering monthly. We have plans to roll out a detailing campaign where we go door to door, clinic by clinic, to show providers how to do it. We're supporting IART in diverse service settings, including the first place was the sexual health clinics starting in 2015. We started that. Here they are, the 8 clinics across the city. A lot of the ending of the epidemic dollars, ETE dollars, went towards staffing these clinics and really ramping up the range of HIV services that they offer, like PrEP, PEP, and now they're doing a lot around reproductive health as well. And then financing IART, like I mentioned, there are contracts that we have where we're incentivizing same day. That's like the incentive is maximal if it's same day, but they still get an incentive within 0 to 4 days of diagnosis. And then finally, the state is expediting the ADAP enrollment process, as I mentioned. And we're monitoring awareness and implementation. That's it. Thank you.
Maybe conclude that the pilot study was instrumental in
Absolutely. Oh yes, definitely. I mean,
that's wonderful to hear.
Before we designed, so I'm in the training capacity building unit, and so at the start, we actually had not developed the training. So the training specifically geared for providers addresses all of these issues around, false positives. It addresses the issues related to which populations can benefit from treatment, going through all the studies that have already been conducted in San Francisco and other places, debunking their concerns. It goes through the insurance. Insurance was listed as the biggest barrier. So now we have a whole module about how to get your patients enrolled in ADAP. And if that's not possible, how to go through the Gilead copay assistance programs. So it really helped to inform everything. Mm-hmm.
Let's see if there are any questions. Let's see.
Yes. Oh, hey! Oh my God, Delette. A lot of friends here. Don't ask anything hard.
So friendly fire, but question. So you did mention your one limitation, which is that it was a purposive sample.
Yes.
And I hear that you intend to sort of monitor the rollout, and I'm just curious.
Yeah.
How are these clinics unique? And how are you thinking about how to characterize what happened that was successful in these clinics as you sort of expand rollout and generalize it? Because people will get more about just why they were selected, what's the nature of those facilities.
Totally.
I presume they sit in the areas with high unmet need. But
totally. Yeah. So I should have mentioned within our unit, we have a clinical operations team that actually works very closely with over 150 different clinics across the city. We make site visits. We have annual surveys that we do. We also work in very close collaboration with the New York State Department of Health, and they're a regulatory body. They oversee Medicaid dollars, ADAP dollars, and so they actually monitor these clinics pretty rigorously. There's a thing called eHIF-QAL, and that they do annually, and they're now actually shifting toward having the clinics submit line-level patient data with basically the cascade continuum information, so time to viral suppression, retention, all of that is now reported. So we do have more than this survey. The survey was sort of a deep dive into, how's IART being implemented, but we have, and we're triangulating, we're doing data analysis to look at our results to see what other, like the racial disparity. We use the survey, one of our annual survey data to look at racial breakdowns of clients served within those clinics. And it's absolutely related to underlying social determinants of health. We know there are clinics that are, small CBOs, many in the middle of the Bronx that have lower rates of viral suppression. And moving forward, our goal is really to support those clinics. And we're actively thinking about, so the new national ending of the epidemic effort is resulting in funding. And so we just submitted a grant to HRSA, and by formula, because we have a lot of cases, we're going to get funding, several $1 million. And we're looking at ways to RFP specifically into those communities. And to make our criteria for funding, the clinics be sort of performance and capacity. Historically, I think we've sort of rewarded clinics that have higher capacity, have grant writing expertise, and we've not done a good job of, really thinking about the social determinants of health. So, yeah.
Ryan?
My question was about the racial disparities and they were existing at the patient level as well, and what you're doing to do that. So,
they're intractable issues that we have to get at. There are underlying, mental health, substance use. It's not just race by itself; it's all the underlying issues. But we think, and the experience from San Francisco, Baltimore, I think they presented at CROI. I haven't seen a paper, but they presented at one of their, I think it might have been Hopkins affiliated, but one of the clinics had a really positive outcome with rapid treatment models, really engaging people of color and maintaining that engagement. Retention was sort of sustained. So we're moving forward, we're looking at how beneficial is this over the long haul. We're able to get people started right away, but do they stick with it, and are they able to maintain their viral suppression?
Last question.
And just along those lines, I think, thinking about the disparity that might emerge, right? Thinking about those kind of issues of medical mistrust, historical trauma, stigma.
Absolutely.
All
Yes.
those issues. Can you see a way to incorporate some of those issues within the IART intervention? Because I think anecdotally from our clinic, what some of the kind of doctors bring up as concerns, or kind of the medicalizing and protocolizing that diagnosis process, where that kind of, it depends on the patient, but that kind of the psychosocial needs and all those other issues might be as important or even more. So can you see a way to kind of embrace that?
I mean, absolutely. I think, I think first of all, we need to get the patient perspective. I think that's, really critical. So more research and work needs to happen to understand how patients receive this. And then I think how you introduce IART to them. I think the U equals U messaging is also really empowering and powerful in a way to potentially increase acceptance of IART. But and I think definitely treating or, addressing, this is a way of also addressing all of the other psychosocial issues, but you don't have to hold their treatment hostage to that, so like doing both in tandem, not in tandem, but at the same time. Yeah, it's critical.
Space for a follow-up pilot.
Yeah, follow-up pilot.
Patient perspective.
Yes. We're done.
Thank you so much.
Thank you.
This is wonderful.
Thanks for having me.